Hi. Today I chose a topic for you, which is a combined medical and surgical issue. But it's certainly one of those issues that we need to be aware of as surgeons because we often end up dealing with patients with liver cirrhosis who might need surgical intervention, and then their suitability for surgery, non-liver surgery, could be a difficult issue to decide on, depending on the degree of their liver function compensation. So I'll go over the basics of the liver cirrhosis, and I'll try during the course of the lecture to point out the clinical issues that we need to be aware of. Now, we all know the etiology, and we should know the etiology of liver cirrhosis, and you're familiar with the fact that some majority of patients who have liver cirrhosis, it's either alcohol-induced or caused by hepatitis C and hepatitis B. But there are other causes that we should be aware of, and these are the autoimmune disease that's called primary sclerosing cholangitis. I do get a lot of questions about primary sclerosing cholangitis from students who are studying surgery, and based on that, I'll try in the future to dedicate a lecture to primary sclerosing cholangitis, which is a medical disease, but there will be some surgical intervention that will need to be done for these type of patients. Hemochromatosis. Now we know that it's an autosomal dominant disease, and it's inherited by a significant proportion in the society, and it's up to 1 in 10 people in the Caucasian demographics will have the one of the genes for hemochromatosis. Wilson disease is a copper metabolism, again one of those inherited or inborn era of metabolism that lead to excessive copper deposition in the hepatocytes, damaging the liver cells and leading to liver cirrhosis in a way similar to hemochromatosis. Alpha-1 antitrypsin deficiency is a rare disease, but again it can lead to liver cirrhosis. And also there's an increasing problem in the society, the metabolic syndrome. Patients with overweight, and particularly those who have morbid obesity, the fat deposition in the liver can lead to liver damage, and this is called non-alcoholic steatohepatitis in general. And it can on its own lead to liver cirrhosis and development of hepatocellular carcinoma. So these are the etiologies. There will be a few other rare problems that could lead to liver cirrhosis, but such as autoimmune hepatitis, but they are not common, and we shouldn't put too much emphasis on them. The process of liver cirrhosis is based on chronic inflammation. So whatever the inciting, the toxic agent that kill the hepatocytes will lead to inflammatory reaction, and that inflammatory reaction is limited to the liver, which will lead to regeneration of liver cells in compensation for the damaged hepatocytes, and also excessive deposition of fibrin, which will lead to fibrosis and scarring of the liver tissue, which start from around the central venule in the area that drain each section of the liver tissue at microscopic level, and that will need to lead to the liver become nodular. It can get swollen, and the nodularity could be macro or micronodular cirrhosis. That does not have much impact on the course of the disease, but there are these terms that we see. They lead to liver failure and formation of hepatocellular carcinoma, but can be different between the etiology. Now, hepatitis C and hepatitis B, in particular, get integrated into the DNA of the hepatocytes, and as a result of that, you see sometimes people are long-term carrier without having chronic liver disease, and these patients will be equally at risk of developing hepatocellular carcinoma because of the integration of the viral genome into the genome of the hepatocytes. Hepatitis C is just a toxic virus that lead to damage of the hepatocytes and the inflammatory reaction that will follow. Alcohol, we know it's get metabolized to acetaldehyde, and acetaldehyde is toxic to the liver cells and have damaging effect on individual hepatocytes, and this will lead to activation of the regenerative process and the inflammation and the fibrosis. In the long term, this process of regeneration that goes for years will lead to development of dysplastic nodules. And the dysplastic nodules are regenerative nodules with the cells in them that have that shows dysplastic changes, and that can be quite sinister because they are precancerous. And once the liver become nodular, the whole liver tissue become a fertile ground for development of hepatocellular carcinoma. There's also increased risk of peripheral cholangiocarcinoma, which appear as a solid mass within the liver tissue. The process of fibrosis tend to make the liver rigid. It might increase in size in the early stages, but eventually when the liver becomes fibrosed and nodular, it shrinks in size and becomes smaller. Usually there is hypertrophy as well, which is very common that we see in the left lobe and the caudate lobe, and that's probably is related to diversion of the blood flow from the portal vein from the right side to the left side due to the increasing resistance to perfusion in the established cirrhotic areas in the liver. Eventually, this fibrotic process will lead to development of portal hypertension. As we know, there will be the inflammatory process, and the fibrosis will lead to narrowing of the central venules, and also it will put pressure on the portal branches, tributaries of the portal vein at microscopic level by the process of fibrosis, which will lead to portal hypertension. Portal hypertension is associated with thrombocytopenia. It can lead to distended veins in the abdomen, and it can lead to also esophageal varices that could bleed. And varices is one of the major issues that we deal with when we have a patient with liver cirrhosis. Now we move on to the clinical presentation. How do we find about them? They either present in the form of sudden variceal bleeding. They present with hemochromatosis as an emergency situation that need to be treated with endoscopy and banding, in addition to beta blockers and an infusion of somatostatin analog octreotide. They can present with chronic anemia, even if they don't have varices or massive variceal bleed. Microscopic loss of blood, so ongoing loss at a microscopic level can lead to chronic anemia. Also, the fact that when the liver decompensates, the process of producing red cells and the bone marrow activity get affected to a variable extent. So the anemia occasionally could be multifactorial, not only related to blood loss, but also to the deteriorating liver function. When we examine these patients, you will find they might have ascites, they might have distended veins in the abdominal wall, such as Hemochromatosis, which is very rare, but very often you see the dilatation of the inferior epigastric veins, as they shunt the blood to the superior epigastric veins, which mean the blood in that case will be shunted to the superior vena cava via the cephalic and jugular circulation. Occasionally, patients present with a mass. Whether they are known or unknown to have cirrhosis, they present with a mass. And usually, if they have a palpable mass as an HCC, they begin to deteriorate rapidly, both in terms of their liver function and also in their general health. Their functional status will deteriorate by losing weight, by having low appetite, by having chronic fatigue. Another phenomenon that we need to emphasize on when we deal with a patient with liver failure or liver disease is encephalopathy. Now, encephalopathy is a clinical term that manifests in the form of short-term memory loss, drowsiness, and they tend to sleep during the day, and also behavioral changes. And these patients or these changes of encephalopathy usually are detected by the family rather than the patient himself. And when you examine them, we look for the hepatic flap test, where we give them to close their eyes and and put their hands straight and put the fingers apart in that way. And then the positive flap, if there is a positive flap, then when they are closing their eyes for a few minutes, they start to make this movement. And that's the hepatic flap. And this is a sinister sign because it means that they have got decompensated liver disease and they have got established liver failure. In addition to the hepatic flap, we'll have a look at the general appearance of the patient. They are emaciated. We take their history. As we mentioned, mainly we focus on alcohol and injectable drug abuse, and also family history of liver disease in case it is caused by hemochromatosis. Also, the weight of the patients will be need to be assessed. A lot of them are anemic. Jaundice is a late presentation and usually means decompensated liver disease. White fingernails due to low albumin. When you examine their fingers, they look a lot whiter despite they are not anemic, or even if they are not anemic, they have white fingernails. Examination of the abdomen will reveal to us whether there is any mass in the liver, also if the liver is enlarged, and in particular we look for dilated veins on the abdominal wall, and we ask them whether they have got excessive rectal bleeding, because some of them will develop rectal varices in a way similar to the esophageal varices process that the body compensates for the high blood pressure in the portal circulation to utilize the collateral circulation, which is in the lower esophagus, lower rectum, and retroperitoneum, to shunt the blood from the portal circulation into the systemic circulation. We asked them about drowsiness and weight loss and the rest of the phenomena and their memory and their behavioral changes, and we look for masses. Now, we go to the patient assessed clinically, and we know their history and their clinical presentation. We need to do a little bit of a workup, and the workup is easy. We do liver function tests, and generally you'll find that those patients will have deranged LFTs. What's important in that derangement basically is the level of the ALT, which give us an indication of the ongoing hepatocyte damage. So ALT will be high if there is ongoing or recent hepatocellular damage, and these patients usually show chronically elevated levels of ALT and AST. The other enzymes could be elevated, such as alkaline phosphatase and GGT. In fact, in a lot of patients, and particularly if they develop liver cirrhosis from drinking, the first change that you will see on their blood test is elevated GGT. High bilirubin is very important. So in addition to the enzymes, we look for what we call the synthetic function of the liver. And the synthetic function of the liver is assessed by three factors: the level of bilirubin, the level of albumin, and also their prothrombin time, or what we call INR, the International Normalized Ratio for prothrombin time. So with the advancement of the liver disease, you find they are jaundiced, they have low albumin, and they have coagulopathy in the form of high INR usually. Other indicators can appear as well, and also the APTT could be elevated, but that's not standardized to measure liver function tests. And then we look at their blood counts, and it's important on the blood count not only to look at the anemia if they need blood transfusion, but we also look at the number of the platelets. And low platelets mean established portal hypertension, and the platelets being digested by the spleen as a result of the congestion. Also, we look for whether they have ascites or leg edema, and this will happen in advanced cases of liver cirrhosis and portal hypertension. An important phenomenon that happen in patients with liver disease is that they will get the hepatorenal syndrome. It's a complex mechanism that affects the microcirculation of the kidney, and that's caused by a variety of defects in the liver function, which will lead to impairment of the renal function, and which will worsen gradually and seen in the form of rising creatinine and EGFR. Now, from a clinical point of view, that's what we do, and we look at their bloods, and we need to do a couple of things once we got them in there. Usually, everyone will have an ultrasound scan, and the benefit of the ultrasound scan is to look for the contour of the liver, and if there are any suspected hepatocellular carcinoma masses. It will also show us whether there is a cystic fluid or gallstone, which is particularly common in people with liver cirrhosis. If we find on ultrasound scan a mass that's suspicious, then we do a CT scan or MRI with hepatocellular contrast to characterize the nature of the lesion further. You see here a CT scan that has got a section of a liver that's with irregular margins, very high, very big caudate lobe, and you could see the left lobe is very hypertrophied stomachache, and also there is splenomegaly. So on CT scan, you should be able to check these factors, and you see these prominent veins, and I suspect that's caused by the portal hypertension. Prominent venous collaterals around the stomach and around the spleen, that's shunting the blood eventually to the esophagus. We do tumor markers for them after that, and these are the alpha-fetoprotein for hepatocellular carcinoma, and we do CA19-9 in case the lesion is a cholangiocarcinoma, because these patients can have either of these lesions, or in fact, there is a lesion that's called collision lesion, where you find a liver cancer in the liver substance, and the histology reveals that it is a combination of hepatocellular carcinoma and cholangiocarcinoma. When we give these patients, it's important if they are in their early stages of the disease and there is no evidence of cancer, we need to put them on surveillance. Now, the first thing is that we will send them to alcohol counseling if they are alcoholic. We treat their hepatitis B and hepatitis C. If they have the viruses, and they get followed up by our liver clinic on 6 monthly basis with an ultrasound scan, liver function test, and alpha fetoprotein. And that is meant to go for a very long period of time, as long as the patient is suitable for treatment. Now, often the diagnosis can become a dilemma where we will see either a mass without high alpha fetoprotein or rising alpha fetoprotein, and there is no mass on ultrasound. Then we do a CT or MRI with a hepatocellular contrast. And the CT scan here that we are looking at is a hepatocellular carcinoma in the arterial phase. You see the aorta is filled with contrast, and you see how the cancer is enhancing in the arterial phase more than the rest of the liver substance, and radiologically it will behave in a usually consistent manner, to the extent that hepatocellular carcinoma is often a radiologic and clinical diagnosis. It's very important to know the stage of the liver disease that we are dealing with, and there are a few staging systems, but the most famous and has been there for a long time is the Child-Pugh scoring system. What does that mean? That means we need to classify the liver. It's a system that classifies the liver status or the liver function into compensated, intermediate, and decompensated. And the compensated will be Class A, Class B is partially compensated, and Class C is liver failure, where patients is, majority of them, will die within the next 2 years. The Child-Pugh score is easy to determine. It depends on 3 biochemical factors, and these 3 biochemical factors are the factors that we call the synthetic function of the liver, the RNR, the albumin, and the bilirubin. So these are the 3 main things that you want to know about these patients if they have got chronic liver disease. And also we assess them for 2 clinical situations. Do they have ascites or portal hypertension, which is the same pathologic process, and we look for encephalopathy. We could check their serum ammonia level if we think they are encephalopathic, and serum ammonia correlates with liver failure. Elevated serum ammonia level are only seen in liver failure. Now, often patients, particularly those in stage B, they have portal hypertension, but they don't have encephalopathy. But any patient with established portal hypertension is considered to be an advanced problem where they will not tolerate surgery on the liver itself. I mean liver resection for hepatocellular carcinoma. Now the Child-Pugh score is available on app that you could get on your phone, or you could do it online as well, and you could put you could experiment on that and put different numbers and see what the results that you get. There is another scoring system, and this scoring system is called the MELD score, Model of End-Stage Liver Disease. And it requires only the bilirubin, the level of creatinine, and whether the patient is on dialysis or not. Again, this one is an app that you can use to see the MELD score level. The MELD score is mainly used in centers where they stratify patients for liver transplantation. But in daily clinical use, we rely on the Child-Pugh scoring system. Now we come to the methods of treatment. What sort of treatment we will need to implement in such patients? Before I go into the treatment, I want to mention the impact of liver disease on patients who's having surgery other than liver resection. They are highly morbid patients. If they are compensate the A and B, they might tolerate major abdominal operation. The risk of complication is higher. However, if they have got stage C liver disease, they are unlikely to tolerate major surgical intervention, such as a laparotomy and bowel resection or gastric resection. But in general, these patients will be suitable for repair of a paraumbilical hernia or an inguinal hernia, which tend to be common in patients, particularly those who have ascites. So when we assess them, we need to, for other surgery other than liver surgery, we need to know their Child-Pugh status, and in addition to other parameter, and see whether they are suitable for surgery, or at least to estimate the risk of mortality and morbidity from doing a major surgery on a patient with liver disease. In terms of treatment, obviously eradicating the cause is the first thing. These patients tend to have portal hypertension, and they have sometimes fluid overloaded, so they need diuretics. Usually use spironolactone because it's potassium sparing diuretic. Furosemide will lead to intractable hypokalemia that's difficult to treat. We also ask them to reduce salt intake in the food. Patients with portal hypertension, they will benefit from putting them on a long-term beta blocker, and the beta blocker medication will reduce the visceral circulation, which eventually lead to reduction of the portal hypertension. Lactulose will be given to patients who are suffering from encephalopathy. And because lactulose can make the bowel motion soft and loose, will eradicate a significant volume of the bacteria to reduce the production of urea, because urea gets produced by bacteria in the colon, and that get absorbed and changed to ammonia, and the ammonia will go to the brain and be changed into false neurotransmitters that lead to the behavioral changes and the encephalopathic clinical features. Low protein diet, and the main aim for that is to reduce the urea production, and that will be implemented in patients with advanced liver failure. Patients with ascites are at risk of developing spontaneous bacterial peritonitis. No one knows why, but it's probably related to reduce their immunity and defense mechanism in the gastrointestinal tract, which will lead to bacterial translocation from the gut, and it does respond well to antibiotics. Esophageal varices, in general, we treat them with banding in addition to the long-term beta blockers. More recently, it has been found that if you put the patient on regular rifaximin, a daily dose of about 300 or 600 milligrams, that reduces the risk of encephalopathy and make them a bit more aware and functioning. I put here two things, which is transplant. I mean, obviously, if the patient has got liver failure and they are relatively young and they don't have cancer, then they would be considered for liver transplantation. That's only for patients who reached stage C in the Child-Pugh scoring system, or scored at least more than 16 in the MELD score, and this is a different topic. The other modality that can help patients, particularly those with esophageal varices, is a technique called TIPS, which is transjugular approach, where it's done by an experienced interventional radiologist who will use the ubiquitous Seldinger technique through the internal jugular vein, introducing a guide wire, and that guide wire will eventually lodge into one of the hepatic veins after it crosses the right atrium. And once they are in the one of the major hepatic veins, then they can make a track between the portal branch and the hepatic vein branch, and with that track they can insert a stent. So it's transjugular portosystemic shunt. That will be useful for people with relatively compensated liver function and have got bad esophageal varices, um, particularly if they are suitable for transplant and there is shortage of organs. Then that particular procedure can be used as a bridge to liver transplant. I think that's all what I have today for you, and I hope it has been a useful and enjoyable lesson, and I will see you in the future recordings. Thank you very much.